And then there's Joyce Shen, and she is a Psych APRN. She will be going over the slide deck in conjunction with Phil. And please feel free to use the chat. We will have medical responding to any chat questions that you have. And if you would like to ask some questions at the end, please feel free to stay on. Medical, which includes Phil and Joyce, will be more than happy to have a conversation and answer any questions that you may have. So without further ado, Phil, if you would like to get started.
Sure. Thanks, Vicki. So hello, everyone, and thanks for joining this journal club today. My name is Philip Lee. I am a pharmacist by training. And with Neurochem Biosciences, I help educate and elevate the awareness of movement disorders, especially tardive dyskinesia. And that's sort of what we'll be doing today. We'll be discussing differentiating the involuntary movement disorders, drug-induced movement disorders specifically. And then my colleague Joyce Chen will be going over the abnormal involuntary movement scale to sort of screen for and differentiate these movement disorders. So we'll go ahead and get started. So these drug-induced movement disorders, what causes them? So DRBAs are the main influence for these movement disorders. So dopamine receptor blocking agents. In our space, it's mostly going to be antipsychotics, but other medications such as metoclopramide that are used to treat nausea also may cause these involuntary movement disorders. That's because we have dopamine receptors all over our body. The second thing I want you to take away from this slide is this term EPS on the right side, extrapyramidal symptoms. So when I started in school, that's the term I learned, but unfortunately, the medical community sort of moving away from this term just because it is a umbrella term that groups these for akathisia, dystonia, drug-induced Parkinsonism, and tardive dyskinesia together. But each of these movement disorders has a distinct pathophysiology. They look different, and more importantly, they're treated differently. So it's important to differentiate, and that's what we'll get into today. Looking at DRBA-induced movement disorders, not only are they presented differently, but their timing of onset is also separate. So the four movement disorders you see on the slide here, acute dystonia, starting with the most earliest onset of action after initiation of a DRBA, is going to be that acute dystonia. And we'll see what that looks like in a few slides with videos included. The second one is going to be acute akathisia, days to weeks to months after initiation of a DRBA. Drug-induced Parkinsonism is also days, weeks to months after starting a DRBA. And then you finally have tardive dyskinesia, which may occur months to years after. So why are we speaking to you about this today? It's because of this increase in antipsychotic prescribing over the past 25 years. There's a few reasons why this trend has gone up, but you can see at the bottom, there's been a fourfold increase in antipsychotic use over the past 25 years. And that's due to the approval of the second generation antipsychotics, also known as the atypicals, as well as the expanding indications for these antipsychotics. So when you have that increase in prescribing of the antipsychotics, you also have that increase in movement disorders as well associated with them. And when those second generations came out, we were hopeful that you wouldn't see movement disorders anymore. And unfortunately, that wasn't the case. You can see here, I won't get into the specifics, but the annual incidence and prevalence of tardive dyskinesia with the first versus the second generation. You can see the first gen in dark green, and then the second generation in the teal and light green. You still do see incidence and prevalence with those second gens, although it is a little less. And I want to direct your attention to the bottom of the slide, where TD is estimated to affect at least 800,000 adults in the US. And another statistic to sort of tag along to that is that around 60 to 70% of these adults are undiagnosed TD. And that's sort of the work that Neurochem is trying to do today, is to raise awareness and the diagnosis as well. Why is it so important to treat these patients, it's because of the stigma associated with
No, I
these
usually count
involuntary
one
movement
Thursday at the
disorders.
end of an hour.
These movements
Yeah.
can
Week or
stigmatize
Tuesday?
patients because they are
gosh,
external,
my
while
stomach's still
sometimes
kind
the
of
serious
weird,
mental
so
illness, the underlying
now
serious
that I
mental
have
illness, can be
this.
more internalized. So these movements may be associated with more severe psychopathology, increase in worsening of quality of life and functioning, lower levels of daily activity, and increased morbidity and mortality. And I'm going to show some videos in a few slides, and I want you to think about if one of your friends or family members had this movement disorder, how would you feel? Or if you were sitting across from someone, how would you perceive them? And what sort of thoughts would you have? So getting into those 4 DRBA-induced movement disorders, starting with dystonia. When you look at acute dystonia, again, the time of onset is going to be hours to days after starting an antipsychotic medication. So it's very acute. The characteristics of this movement are this sustained muscle contractions. So it may look like pulling, twisting, repetitive movements, primarily located in the neck and the facial region. And they may present like torticollis or neck extensions, trismus, lockjaw, jaw opening, grimacing, blepharospasms, which are issues with the eyelid, and some other clinical features may include like muscle pain or cramps, anxiety, issues with breathing. And let's take a look at an individual with acute dystonia. So you can see already that sort of extension in the neck, opening of the mouth. And acute dystonia can be very painful in patients. Because it is painful, it's important to treat them with the appropriate medication. And the treatment approaches for these movement disorders comes from the 2020 APA schizophrenia practice guidelines, which are the most recent guidelines for treating these types of movements. So the 2020 APA guidelines state that anticholinergics are going to be first line. So benztropine or cogentin or trihexyphenidyl or artane. Other recommendations include antihistamines with anticholinergic properties like diphenhydramine or Benadryl. And benzodiazepines also may alleviate those symptoms. And another option that's not in those guidelines is Botox, which is indicated in their package insert for cervical dystonia or neck dystonia, as well as blepharospasms. Looking at the clinical characteristics of akathisia, acute akathisia, the time of onset after DRBA is going to be days to months after initiation. And what does the movement look like for akathisia? It's going to be an inner feeling of restlessness, this urge to move, inability to stay seated. It may be associated with some stereotypies like foot tapping, shuffling, shifting of weight, and rocking. A lot of people say they feel like a burning sensation or itching and crawling in their muscles, and it's very uncomfortable. So let's take a look at a patient with akathisia. You can see already sort of shaking the legs, that uncomfortableness, trying to leave, wondering how long she has to be there. So it really is characterized by that inner feeling of restlessness. And something I do like to point out is that sometimes akathisia can be confused with restless leg syndrome. However, akathisia is differentiated in that restless leg syndrome is primarily in the legs. And when you have restless leg syndrome, if you move around, if you stretch, if you walk around, it alleviates those symptoms. But with akathisia, that feeling of restlessness does not go away when you move around or walk. Now, how do you treat akathisia? Again, looking at the 2020 APA guidelines, It's recommended to either lower the dosage of the antipsychotic medication or switch to a lower risk one. However, you always want to take into consideration the patient's underlying serious mental illness, and you sort of risk destabilizing that patient. So you have to weigh the pros and cons of lowering the dosage or switching. There are other medications that help treat akathisia, such as a beta blocker like propranolol or benzodiazepines. There's also other studies that show mirtazapine may be effective, but those are not clinically proved. And looking at the third drug-induced movement disorder, looking at drug-induced Parkinsonism, the typical time of onset is going to be days to weeks to years after that antipsychotic medication. And the movement characteristics really revolve around three primary characteristics. It's going to be bradykinesia, rigidity, and the tremor. And less commonly, I would say the tremor. So all these movements sort of fall under those categories, that tremor and bradykinesia, like we said, that rigidity. Sometimes you can see them when they're walking. They have reduced arm swinging. Other ones you can see are the hypomimia, or the masking of the facial expressions. A lot of times you can see that sort of blank face in these individuals. Also reduced blink rate, other things that I've mentioned, flexed posture, shuffling or freezing gait, rabbit syndrome, where individuals may have a tremor in the lower jaw that mimics sort of a rabbit chewing. So let's take a look at an individual with drug-induced Parkinsonism. So you can see here sort of that tremor in that hand, maybe even the masking of the facial expression. And again, this is just one case of drug-induced Parkinsonism. You can sometimes see that issues with gait or walking, issues with rigidity in the arms as well. And looking at the treatment for drug-induced Parkinsonism, again, the 2020 APA guidelines recommend either lowering or switching the antipsychotic medication. But again, you have to weigh the pros and cons of, again, destabilizing the patient. Some therapeutic options include anticholinergics like benztropine or cogentin. Those are also available. So again, antihistamines with anticholinergic property like diphenhydramine or Benadryl. And amantadine does have like single case studies out there that may or may not show efficacy. Then finally looking at the last drug-induced movement disorder, tardive dyskinesia. It's clinically distinct and delayed DRBA-induced movement disorder. It's going to be the latest of all four of those. So it's defined as abnormal involuntary movements of the tongue, jaw, trunk, and extremities. So a lot of physicians say that they see TD in the orofacial region. And it's characterized, the movements are characterized by coriform athetoid movements, which mean rapid, jerky, non-repetitive, some say dance-like movements, or athetoid, which are slow, sinuous, sort of serpentine movements. And those may seem a little different, and that's because TD affects muscles. And you have muscles at the top of your head to the bottom of your feet, and it looks different when you have TD in different parts of the body. Now let's take a look at an individual with TD. So you can see here in the orofacial region, in the neck, as well as the tongue. Sort of see that back and forth when asked to stick their tongue out. See it in the neck and that tongue movement as well. Then when you see the individual standing, You may see some tardive dyskinesia in the shoulders or maybe the neck still, in the hands as well. So again, imagine having these sorts of movements and being out in public and being unable to control these movements. Take a look at another individual. That foot tapping in the face as well. So you can definitely see how it may affect that patient's quality of life. Looking at the individual standing, you can see that they may have issues with even walking or feeding, and the stigma that may be associated with this. So finally, moving forward, how do you diagnose TD? So it's diagnosed through clinical evaluation and patient history. An AIM scale may be used to screen for TD, but the only way to diagnose is through the DSM-5 criteria, which says the movements must be present for at least 4 weeks. The history of the offending agent for at least 1 month in those older than 60 and 3 months in those younger than 60 years of age. So tardive dyskinesia in those older than 60 can appear in less than 1 month after initiation of an antipsychotic. And signs of TD may develop during exposure of the DRBA or within 4 weeks of withdrawal from an oral DRBA, within 8 weeks of withdrawal from a long-acting injectable as well. Now, how do you treat VMAT2 inhibitors? Or how do you treat tardive dyskinesia? It's going to be with the FDA-approved VMAT2 inhibitors. These are FDA-approved medications for tardive dyskinesia. And when you look at the 2018 update to the ANN guidelines, as well as the APA guidelines, they recommend VMAT2 inhibitors for moderate to severe disabling TD and can be considered in mild TD as well. And I do want to mention that TD, again, looks different in every individual. So, it has to really be a clinician and team effort to determine whether or not a treatment is recommended for that specific individual. Another thing I do want to mention is that anticholinergics are not recommended for use in tardive dyskinesia. And that's because it can actually make TD worse. And when you look at the benztropine guidelines, it actually states that it can be used for drug-induced Parkinsonism, but not for TD. It's also in the Beers criteria because of the risks in older adults for increase in dementia, fall risk, as well as cognitive decline. And finally, again, I want to say that one size doesn't fit all. So that's why we need to differentiate these movement disorders so that these individuals can be treated appropriately for the best patient care. With that being said, I do want to hand it over to Joyce to go over the abnormal involuntary movement scale.
All right, Phil, thank you so much for setting that up for us. Hello, everybody. My name is Joyce Chen. As Phil mentioned before, I am a psychiatric nurse practitioner, and my practice background is homeless and severely mentally ill. And I mentioned that because that's going to come through as we talk about doing the AIMS exam, which is really the gold standard that clinicians use to assess for the presence of and the severity of tardive dyskinesia. Now, before we jump into it, I'm going to ask Rachel if she can please drop the Mind TD questionnaire and the AIMS tear-off sheet into the chat. Audience, you don't need to use it right now. I'll let you know when these documents will come into play, but if you could just have them open and just keep them in the background for right now as I go through the next steps. So, Phil, we're going to go to the next slide. Okay, so what is the AIMS exam? Okay, so and how often should we be administering it? So according to the APA schizophrenia guidelines, really anybody on a DRBA should be assessed formally or informally at every encounter. Now, how often should we be doing the AIMS specifically? At least at baseline, and at least every year for anybody on a DRBA, typically our antipsychotic medication in psychiatric world. Now, however, if you'll notice here, it says that for those that are at higher risk for tardive dyskinesia, we should be doing this Ames exam at least every 6 months, if not sooner. So then who is considered to be at higher risk? Well, a lot of different people, actually. So those who have been on a lot of first generation antipsychotics makes sense because they're much more potent dopamine receptor blocking agents. Those who have been on multiple different antipsychotics in the past, again, makes sense. That cumulative exposure piece really puts somebody at higher risk for developing tardive dyskinesia. Other things, such as if you've ever been on an anticholinergic, such as benztropine, cogentin, artane, or trihexyphenidyl in the past, things like if you've ever had a history of substance use, not just any specific substance, but substance use in general. And again, I worked homeless and severely mentally ill. So for my patients, that meant 99.999% of my patients were at higher risk for developing tardive dyskinesia. Some other interesting statistics as well. Those with a history of mood disorder are actually at higher risk for tardive dyskinesia. Now, a lot of clinicians associate schizophrenia with tardive dyskinesia, but actually those with a mood disorder such as depression, dysthymia, bipolar, etc., are the ones that are truly at higher risk. Those that are elderly and those that are postmenopausal women are also at higher risk. So I say all of that so you can start thinking about your Rolodex of patients as to who you might consider screening a little bit more frequently for tardive dyskinesia. Next slide. Okay. Okay, all right. So with that being said, let's jump to what the Ames looks like. So if you've never seen the Ames exam scoring sheet, this is generally what it looks like. Once again, it is the gold standard that clinicians use to assess for the presence of and the severity of tardive dyskinesia. It is a screening tool, however, and it is not diagnostic. And I'll tell you why in just a moment. But the Ames test is split up into 7 different body regions. You have the face and oral movements, you have the upper and lower extremities, and then you have the truncal movements. Each of these body regions, the clinician scores from a score of 0 to 4, 0 being no movements whatsoever, 4 being the most severe. And at the end of it, you tally up all the scores to get a total Ames score. So if you can do your math right, you have a total score of 28. And all the other items on the Ames score are related to the global severity of these types of movements. Next slide. So one of the questions that's running through your head right now is what is exactly like a 0 is pretty straightforward, right? No movements whatsoever. A 4 is very severe. You can see it from clear across the room. But what is exactly a 1 versus 2 or 3? Unfortunately, there's no concrete guidelines on how the clinician should be measuring this. However, there are a lot of recommendations that I'm going to be making throughout this to start helping train your eye so you can be internally consistent with yourself when you're scoring the Ames. Okay, so one of the first ways you can consider this is by looking at the amplitude and the frequency of these types of movements. Okay, so how often the movements are occurring during the session and how severe the movements are when they are happening. Okay, next slide. Okay, so the reason I said that the Ames test is not diagnostic is because the total Ames score is really just a number. It doesn't necessarily tell us definitively if somebody has mild, moderate, or severe tardive dyskinesia. It's just a score. So I'll give you an example. Say you have patient A. Patient A has very severe movements in the oropharyngeal area, okay? So maybe their tongue movements are so severe to the point where they can't talk, they can't chew, they can't swallow because their tongue's just moving around in their mouth all the time. But they have no movements anywhere else. So if you remember the Ames score, they have a score of 4 in the tongue and 0, 0, 0 everywhere else. So their total Ames score is going to be a 4. Now you have patient B. Patient B, maybe they have some slight lip puckering like this, if you look at my video. A little bit, not really impacting them too much, just here and there. Maybe they have some slight finger tapping. Maybe their toes are flaring a little bit here and there. Maybe they have a little bit of shoulder shrugging. So they have a score of 1 in 4 different body regions. So their total score is also a 4. So you have patient A, patient B, both with a total score of 4. But as a clinician, if I were to ask you which of the patient's movements impact their life more severely, I would imagine that most of you would say that patient A's movements are much more impactful to their life. So therefore, that's just an example to show you why a score is just a score. So then how do we actually use the aims? Well, the thought is that you as a clinician are the ones that's performing the aims over time. So you're the one doing it over and over and over again. So the most important part of this training is that you want to be internally consistent with yourself. So when you are scoring somebody and you score somebody a 1, 2, or 3, you can feel very confident that you know whether the trend of these tardive disconnected movements are improving or if they're worsening. Okay, next slide, please. Okay, so that's a brief overview of the AIMS exam itself. And so now we're going to move on to how to actually perform the AIMS. Now, I understand most of you and most of the world right now, we work in kind of modified patient settings. A lot of us are doing work over telehealth. Maybe we're working with patients who are developmentally delayed. Maybe we're working with patients who are bedbound, wheelchair bound, whatever the situation is. We're going to go through the gold standard way of how to do the AIMS, but then I'll talk you through some modifications you can make depending on your patient setting. Okay, so in our gold standard environment, we're going to have the patient in the waiting room, and then they're going to be brought back to the office. So actually, you can start the AIMS exam as the patient sitting in the waiting room and walking backwards. Back to the office. You can already start seeing the patient's gait. You can see their overall global impression, and then they come back into the office. Okay, once they're in the office, you're going to ask the patient to ideally sit in a hard and firm chair with no arms, because you don't want the patient to grab onto the arms of the chair to potentially mask any movements. You also want to ask the patient to remove their shoes or socks. Okay, again, I worked homeless and severely mentally ill. There was no way, no how I was ever going to get my patients to remove their shoes or socks. And that's okay. You simply document it and you move on. So the question is then, how do you get to assess the feet if the patients don't want to remove their shoes or socks? Or how do you assess for movements if the patients refuse to do some sort of part of the exam? You can ask probing questions to kind of go around it to see what the potential impact of these movements are on the patient. For instance, you can ask questions such as, how often are you rubbing holes into your socks or your shoes? How often are you replacing them? Do you have any pain in your feet? Do you have any difficulty clipping your toenails? So when you're thinking about these probing questions, think about the potential functional impact that these movements could have to the patient. Okay. With that said, you also want to make sure you're asking the patient some additional questions surrounding their mouth, such as, do you have any pain with your teeth? Do you have any dentures? Are you chewing any gum or any candy? Because definitely those types of movements can look very similar to tardive dyskinesia. Once again, if they do have ill-fitting dentures, doesn't mean that you don't do the assessment. You just document it and move on. Okay, so with that said, we're going to get to our videos, and these videos will give us a better visualization of everything that I'm talking about. So as Phil's playing through the videos, I'm going to talk over them so you can see exactly what is going on. So here you can see the camera's already panning from the feet on up to the face. So anytime you're doing the AIMS, no matter what you're asking the patient to do, you're always doing a global assessment. You're always scanning from head to toe. So the provider's taking the patient now back to the office. And then once the patient's in the office, you're going to ask the patient to sit with their feet about shoulder width apart. And ideally, you want the patient to dangle their hands over their knees. Again, not grabbing onto their knees, because then they can mask some potential movements. So pay attention to some of the movements that are already being illuminated just by this conversation. Providers asking the patient right now, do you see any abnormal movements? Do you have any issues with their teeth, etc.? You can start seeing already some of those hand movements coming out. You can see some of the lip smacking, and you may have been able to see some of the foot tapping earlier too. Now, if you, like a majority of the people now, are working in a telehealth session, sometimes you can't see their full body. Sometimes maybe the camera is like way up there in the corner. Maybe they have the camera way up here in their face. So how do you do an assessment that way? Couple different techniques. Ideally, what you want to do is you want to have the camera propped somewhere on a hard surface. So maybe ask the patient to place their phone on the side of their desk, side of their bed, against the wall, and then have the patient step back so you can see their full body. So that's one of the techniques. Again, then we're going on to the next slide, please. Okay, so we've had the patient sit in their chair. So the next thing we're going to have the patient do is to open up their mouth. Now, key thing, whenever you ask the patient to do a movement, you want to make sure that you're doing the movement for the same length of time that you want them to do the movements, because otherwise, this is what's going to happen. Okay, if everybody could look at my screen. Okay, patient, can you please open your mouth? You see that the patient will open their mouth for exactly 0.1 seconds, which really doesn't tell you anything about whether or not they actually have movements. So you want to make sure that if you're asking the patient to open up their mouth, that you are also doing it at the same length of time, like like that. Keep in mind that asking these patients to do these movements can be very embarrassing for the patient. They don't know why you're asking them to do these things. So try to make it fun. Try to make it lighthearted. If you have a patient with, let's say, a developmental disability, a very good technique is to do something like Simon says. Simon says, let's open our mouth. And then they'll be much more liable to actually perform the movements you're asking them to do. Okay, so what we're looking for when we're asking the patient to open up their mouth, you want to see their tongue at rest. And again, you always want to do that global assessment of other body regions to see what else is going on. Okay, next slide, please. So we've had the patient sit, we've had the patient open up their mouth. Now we're going to have the patient stick out their tongue. Once again, make sure when you're asking patients to stick out their tongue, you're sticking out your tongue for the same length of time you want them to do it. And make sure you're holding this for at least a couple of seconds, because what you'll find is that the longer you ask the patient to stick out their tongue, if they do have abnormal movements, their body will subconsciously focus on their tongue. So other movements in their body may become more prominent, or their tongue movements themselves can become more prominent the longer that they stick out their tongue. So you can see there in that video, the longer that this patient is being asked to hold out the tongue, those foot tapping movements become more prominent. Okay. So we'll play it one more time just so you can see that. So it's sticking out the tongue. And then it's going to zoom out, and you can start seeing those foot movements become more prominent. Okay. Next slide. Okay, so we've had the patient sit, open up their mouth, stick out their tongue. Next thing we're going to do is do the finger activation maneuver, okay? So you're gonna have the patient stick up their hand one at a time and try to tap their finger to their thumb as fast as they can. Now, again, now you wanna do this for the same length of time you want them to do it. Patient thinks you're looking at how well they can tap their fingers to their thumb. So they're focused on this, but actually, this is an activation maneuver. What we're trying to do is have the patient focus on one thing to help illuminate those movements that are happening in other body regions. So you can see the patient's mouth here, those lip smacking, those chewing movements are becoming much more prominent. And those foot tapping movements are becoming much more prominent the longer that she's being asked to do this. That doesn't necessarily mean we don't care about how good they're able to do this movement. If you're doing it very slowly, it could potentially be a sign of bradykinesia or slowness of movement, which is very oftentimes associated with Parkinsonism. But really, we're trying to do that global assessment. So you can do one hand at a time and then switch to the other hand. Okay, next slide. Okay, so we've had the patient sit, we've had the patient open up their mouth, stick out the tongue, finger activation. Next thing is we're going to do the cogwheel rigidity test. If you've ever done a neuro exam, this is going to look very familiar to you. Essentially, you want to ask the patient to relax. You're going to grab the patient's elbow with one hand and grab their wrist with the other. And you as a clinician, you're going to gently raise and lower the patient's arm to note any signs of rigidity, which could be a potential sign of drug-induced Parkinsonism. Now, please note that this specific question is not scored on the Ames test. This is more of a rule out to make sure you're not dealing with drug-induced Parkinsonism, because certainly Parkinsonism and tardive dyskinesia are the two drug-induced movement disorders that get mistaken for each other most frequently. And unfortunately, their treatments are quite opposite. And if you potentially treat one with the wrong thing, you can worsen the other movements. Now, once again, I work with severely mentally ill, homeless patients. There was no way that they were going to let me get close enough to actually do the cogwheel rigidity test. And if that's the case, that's okay. You just simply document it and you move on. Okay. Okay, next slide, please. Okay, next thing we're going to do is we're going to do the standing arm activation maneuver. Okay, we've had the patient sit, open up their mouth, stick out their tongue, finger activation, cogwheel rigidity. Now we're going to have them stand. Okay, disclaimer. I did not make this video. I was not consulted in the making of this video. I have critiques about this video, if anybody can imagine why. Please, if you have a patient who needs an assisted walking device or have imbalanced gait, please do not take their assisted walking device away from them. Different things that you can do. You can hover with your arms around them to make sure that they don't fall. You can have a railing next to them. You can put a chair in front of them. You can have a gait belt around them. There's lots of different techniques to make sure that they don't fall, because of course we're always thinking about our safety risks. Okay. Now, the thought is, though, if you have the patient stand, you will be able to better see, once again, that global assessment of those types of movements, predominantly in the trunk, leg, and legs area. You can see their balance, you can see their gait. If we're looking at the truncal area, some things you might be looking at would be like if there's any swaying, any gyration of the hips, things like that. Now, let's say you do have a patient who needs an assisted walking device, or maybe they're wheelchair bound, bed bound, maybe they're paraplegic. Do you just not do the Ames? No, you can still do the Ames. You just document what you can, ask probing questions around the rest, and then you can always try to get some collateral information from family or friends as well. And that's also a good technique if you're doing an assessment over telehealth, because again, oftentimes we're only seeing these patients for what, 10, 15 minutes at a time, especially over telehealth. Sometimes you're only seeing half the body. So if you can't see any movements, ask friends or family if they can provide any collateral information. Ask friends or family if they can take a video of the patient and submit it to you for review as well. Okay. And then I know that it seems like we're not able to have any attachments added to this. That's okay. If you go on the MindTD website, there is a MindTD questionnaire, which you can download, you can print out, which is very, very helpful. So that front page is very helpful, particularly if you're doing anything over telehealth or video call or a phone call. It gives you ideas on questions to prompt whether somebody may have tardive dyskinesia or not. It's not the Ames exam, but it gives you some probing questions. And on that back page is the checklist between tardive dyskinesia and drug-induced Parkinsonism symptoms to help you differentiate what the patient may actually have. Okay. Next slide, please. Okay, so finally, what we're going to get into is the walking activation maneuver. All right, so we've had the patient sit, open up their mouth, stick out their tongue, tap their fingers. We've done the cogwheel rigidity. We had the patient stand. Now we're going to have the patient walk. Once again, please do not take their assisted walking device away, or if you are, make sure you're hovering around them, having a railing next to them, doing something to ensure their safety. And also keep in mind that especially with the standing and walking activation maneuvers, you can actually do this as the patient's walking back to the office with you. There's no one saying that you can't kind of break it up or change the flow of the Ames exam. As long as you are able to see the movements you're looking for, it doesn't really matter so much how you're doing it. You don't need to have the patient walk a mile by any means, especially with our offices. Generally, a lot of them are pretty small, tight quarters. Just a couple of steps can be long enough for you to see how their balance and gait is. And so with that, I think that is, we will move on to the next slide. Yep, that is how to conduct the Ames exam itself. So pretty straightforward. So really the only things they're asking them to do are to open up their mouth, stick out their tongue, and do that finger activation maneuver, the cogwheel rigidity test, and everything else you kind of modify based on what's going on in that setting with that particular patient. Okay, so I know I zoomed through that. Any questions, please feel free to type it into the chat. But we're going to move directly on into our case study. Okay, so this is where the Ames tear-off sheet can come in really handy. If you don't have that, that's fine. If you can grab a pencil and a paper, what we're going to do is we're going to go through an actual patient that was submitted to our clinical trials, and we're going to score this patient as if they were our own. So we're going to do it all together. We'll do items 1 through 7 all together so we can get an idea of how to start calibrating our internal eye. Okay, so we have our patient here. This is their patient history. Age 41, diagnosis schizophrenia. This is the medication list. Of note, no antipsychotics on this medication list, which tells us, again, that you don't currently have to be on an antipsychotic in order to have tardive dyskinesia. So it's possible that she had a history of being exposed to one. Okay, next slide. All right, so all together now, what I'm going to do is we're going to take a look at these videos. So we're looking at item 1. So we're only looking from the cheeks on up, okay? So I would like everybody to type into the chat what number you think this patient's movements are. So try to ignore everything that's happening with the mouth right now. Just type into the chat what you think, whether it's 0, 1, 2, 3, or 4. Okay, so I'll give you a moment to do that. If you're hesitant about scoring because you don't want to score the wrong thing, don't be hesitant, because again, the thought is that you want to be internally consistent with yourself because you are the one that's going to be doing the Ames exam on these patients over and over. It really does not matter what the clinician next to you scores, because everybody's scores is so subjective. Okay, so you just want to make sure you're internally consistent with yourself. Well, for demonstration's sake, I'm going to ask everybody to type it into the chat. All right, and then so in case you are curious, this is what our central raters did put. Okay, so they put, this patient was admitted for our clinical trial studies, so our raters put the score as a 1. Now, if you didn't put a 1, do not change your answer, just write down that 1. We're going to add up all of your individual scores at the very end, okay? So, and then we're going to move on to the next items. Okay, so now we're looking at items 2 and 3. So we're going to look at item 2 first. We're only looking at the lips. And then we're going to look at the jaws. So write down whatever you think the lips and the jaw are. Now, these movements can be very difficult to tease out from each other. So one of the ways I like to think about it is looking at where the movements are originating from. If the movements are originating more from these mandibular areas, probably more closely related to jaw. If the movements are more localized to the front, probably more related to the lips. Okay, so with that in mind, go ahead and take a look, just score whatever you think it is. Now, another way to think about these types of movements, we already talked about amplitude and frequency, so how often these movements are occurring and how severe they're occurring at the same time. Another way to think about it is by thinking about you're on a bus. How far away do you have to be from the patient in order to see these movements? If you can see these movements when they're sitting on the other side of the bus from you, it's probably closer to a 4. If the patient has to be sitting right next to you in order for you to see it, probably a 1. But if the patient has to be a couple spaces away from you and the patient, then it's probably closer to a 2 or 3.
Joyce, just wanted to chime in here. I'm seeing some 2s come through in the chat.
Okay, perfect. Okay, so it looks like people are putting 2. So let's see what our central raters put. Okay, so they scored item 2 as a 1 and item 3 as a 2. Now, again, if you did not put a 1 or a 2, do not change your answers, just keep it. And I know I just said that it doesn't matter what the clinician next to you put, but the reason why we have these central rater scores on here is just to kind of give you a reference, because I know some people really like to see what other clinicians did put. Okay, and thank you guys who did respond in the chat for your bravery. I know it can be scary to expose yourself like that, but I think you'll find out very soon that it's very common for us to have different answers. Okay, Next slide. Okay, so now we're moving on to item 4. Okay, so now we're looking at the tongue. Again, remember what I said, the longer this patient's sticking out their tongue, look at these movements. They weren't there at the beginning, but the longer the patient's being asked to stick out their tongue, they become more prominent. Okay, so go ahead, type into the chat what you think the patient's movements are. I'll give you one more tip on how you may want to assess these movements. If you're ever struggling between scores, so maybe you don't know if it's a 2 or a 3, think about the potential impact that these movements have to the patient, right? Because at the end of the day, we're doing this all for the patient. That's why we're doing the aims in the first place. So you don't have to be conservative with your numbers. Again, just as long as you're internally consistent with yourself and you can see a trend over time, that's what we're more so concerned about. Okay. All right, Rachel, what
Joyce,
am I
I'm seeing, yes, great minds think alike. I'm seeing a 1, I'm seeing some 3s and 2s.
Okay, okay. So we're seeing a little bit of difference, and that's okay. Again. All right, so this is what our central raters put, and they scored this as a 1. Now, if you didn't put that, that's okay. And I'll tell you something else. So in our Connect 4 trials, we actually had our central raters who were off-site. So we had 2 movement disorder specialists who just received hundreds and hundreds of videos and they just scored them. We also had on-site raters who were typically the psychiatrists working directly with the patients on a day-to-day basis who also scored the patients. Our baseline demographics show that our central raters on average scored the patient's movements at a total score of 10, while our on-site raters scored the same exact movements at an average of 14. So that just once again just goes to show you the differences between scoring. So do not feel bad or discouraged if your scores do not match up with the person's next to you. Okay, next slide. Okay, so now we're going to move on to the upper extremities. So we're trying to ignore everything that's happening from the trunk on down, only looking at the arms, wrists, hands, and fingers. What do we think this is? Once again, type into the chat. Think about the functional impact. Think about how often these movements are occurring, how severe these movements are when they are occurring, and how far away do you have to be from the patient in order to see these movements? Okay. I know it can be very confusing to see when there's a lot of other things going on, but this is all part of training that eye.
All right, Joyce, I'm seeing a 1, I'm seeing a 2 so far, another 2.
Okay, so we're getting 1s and 2s. Okay, so let's see what our central raters put. They're also put a 2 as well. Okay, all right, you guys are doing great. We are almost done, so we're going to move on to item number 6. Now we're going to talk about the lower extremities. Okay, so now, once again, ignoring everything from the hips on up, only looking at the legs, knees, ankles, and toes. So trying to ignore the swaying that's happening, only looking at the legs, knees, ankles, and toes. What do we think this is? 1, 2, 0, 1, 2, 3, or 4? Is it something? Is it nothing? How impactful could these movements be to the patient?
Okay, seeing a 2, seeing some 3s come in.
Okay, 2s and 3s. Okay, seems pretty consistent. All right, and then we'll see what our raters put, and they also put this at a 2. All right, so now we are going to be talking about item number 7. This is our last item. So ignore whatever's happening with the hands, ignore whatever's happening with the legs and feet, only looking at that truncal section, which includes the neck, shoulders, and the hips. What do we think this is? Is it something? Is it nothing? How far away do you have to be to see anything? How impactful are these movements? And we'll play this one more time. Type your answer into the chat.
All right, we're seeing 1s so far.
Okay, all right, we're pretty consistent with our 1s then. All right, and then our central raters also put a 1. Okay, so now what I'm going to ask you all to do before we move to the next slide, please add up your total score and type your total score into the chat. Okay, I'll give you guys a second to go ahead and do that. Okay, and as you guys are doing that, we're gonna move to the next slide. And then one more slide, please. Okay, so what was our, in general, what did we get?
I'm seeing some 9s, Joyce.
Some
We're
9s.
getting some 9s.
Okay.
110.
Okay, 9s and 10s. Okay. And I see an 11 as well. Okay, so thank you all to those who participated, and it's okay if you're shy and didn't feel like responding right now. So just so you know, our central raters, once again, they put this total score of a 10. But if you notice, it didn't really matter what you as a clinician individually put on each body part. In general, the scores were about 9 to 11, which is right around the same ballpark, right? So again, really, that's kind of what we're looking for, right? Like we all in general agree that this wasn't a 28. And we all generally agree that this wasn't like a 1 or a 2. It's somewhere kind of in the middle. Okay, so hopefully that helps you feel a little bit more empowered when you are doing this exam, that you don't have to exactly match up with the person next to you. Hopefully this helps you start feeling more confident in scoring identifying what's a 1 versus 2 versus a 3. And we can move on to the next slide, please. With that said, really quickly, once again, just wrapping everything up, we're going to talk about TD treatment guidelines. Phil already did a great job talking about our VMAT2 inhibitors. But one final note I wanted to make is look at the bottom of the screen. These are all the things that are not indicated for tardive dyskinesia. Anticholinergics, we already discussed why, but also changing the antipsychotic or discontinuing the antipsychotic, because tardive dyskinesia very most often is a chronic irreversible condition, meaning even if you take away the offending agent, those movements will still be there, and now you have 2 problems instead of 1. Next slide, please. Okay, so in general, now you should have a better understanding of the different types of drug-induced movement disorders. And the AIMS is the gold standard that clinicians use to screen for tardive dyskinesia. Really, we should be assessing anybody at baseline who is on an antipsychotic medication, and at least annually, if not every 6 months for those that are at higher risk. Okay, and then if you have, the next slide, please. If you have any additional questions, I mentioned a couple of resources, but here's some final great resources. These are all free to you as a clinician. I'm going to go over them very quickly. First one is Discover TD. It's an interactive game using virtual avatars. There's teaching cases and challenge cases that talk about the different drug-induced movement disorders. You go through an actual patient case scenario from talking to the patient, doing the AIMS, diagnosing and treating the patient, and you get a case report at the end. Great, particularly if you don't see a lot of drug-induced movement disorders, to help refresh your brain. If you want more information, education on this, the DIMD course is a great resource. For free online modules, you get a cool little certificate at the end. And finally, our Neurocrine Medical website has an entire repository of resources, including articles, clinical data, and hundreds and thousands of patient videos if you're so interested. And Rachel's going to drop our contact information into the chat one more time. If you would like any more education or more discussion about this one-on-one, Phil or I will be happy to chat with you a little bit more. So with that, I would like to conclude my part of the presentation, and we do have about 5 minutes left if anybody has any questions. And Phil, we can see your screen. Okay. And if not, then I'll turn it over to Vicky for last comments.
Hey, Vicky, before you speak up, I just wanted to, you're on mute.
Come. You wanted to say something.
Yeah, I just wanted to thank the Neurocrine team for being on here and providing this education. We will be following up. We plan to post all the materials in our LMS, or at least in a folder that everyone should be able to access, so that we'll be able to share. Because if I'm understanding correctly, and I missed the very beginning of this meeting, but we'll be able to have access to the videos and a lot of this information for our providers to be able to access. So we'll make sure that we put an email out to the team once that's available. But I appreciate everyone's willingness to engage, and including scoring with the live kind of patient interaction demo. And Vicky, I'll turn it over to you to
Yeah.
close us out.
Yeah, thank you. And yeah, they'll be available through Neurocrine Medical. So please reach out to us if you have any questions at all. We're more than willing to connect you to medical and connect you to the resources that you need in order to make or implement these resources as needed to help you out.
Thank you very much.
Any more questions? Great. Well, I thank you so much for this opportunity. I hope you took a lot away with this, and look forward to connecting in the future.